Okay, so I'm going to be doing a review for you for the upcoming test, and I'm going to go over all the different lectures I've done for you recently so we can have that. First thing I'm going to do is I'm going to start with our drug calculations. Again, we are looking at the formula basically when I am giving you a drug amount to be given and you have a vial or concentration on hand. What is the amount of milliliters? These are the only questions I'm going to ask you on this particular test. There's going to be no drip formulas, even though I'm going to go into that a little bit for you here in a minute. So again, this is going to be our formula here, volume on hand times the ordered dose over the concentration. Remember, show your work on this, write out milligrams, write out milliliters, do all your cross multiplication so you guys get used to knowing exactly where it is so you come up with the correct answer. Now for this test, I do want you to be able to take this out to 1/100th of the decimal point. So for instance, you could have a calculation that comes out to be 10.50 or 10.25. So take it out to that full amount for this test question. For the next test, I'm going to have pretty even numbers for you, which will only go out to the 10th place. But for this, we're taking it out to 100th place. I told you before that we could round up to the nearest number. For this test, take it out to the 100th point, then you'll see. It'll be like a 10.25 number or a 9.75 or something to that kind of extent. Obviously, it's not going to be anywhere near that because I'm not going to give you the answer, but take it out to that point for this for this test. So here's our example. You're told to give 2 milligrams of a medication. Your vial concentration is 10 milligrams in a 5 milliliter vial. How many milliliters are you going to give? So you're going to set this up so your milligrams cross out. 5 mils times 2 milligrams divided by 10 milligrams. Milligrams cancel out. And basically what you're looking at as 10 over 10, and so you're looking to give 1 mil to give that dosage. Makes sense? Hopefully that's pretty easy. I think we knocked that one out pretty good. So I'm going to go ahead and go on to the next, which was our drip rate. And again, I just want to reiterate this one for you as far as this formula. You guys have got to memorize this formula for the next test. For this test, no, but for the next test, this is going to be the key formula. And we're going to give you another homework example if you don't already have those. Again, looking for these type of questions. And there's the type of question that you're going to have. So again, you're looking to give 5 micrograms per minute is your ordered dose. You have 1 milligram in 5 mils. Remember, the 5 mils is not important. You have a IV bag of 250 milliliters, and the patient's weight in this particular case, remember, is not important. So the next question will be, now use it instead of a micro drip, a macro drip. Should be pretty simple and pretty straightforward. So those are what we're looking at. Alex asked for a question again, so I'm going to pop this out again. There's another question. So there I've shown you 2 different examples on there. Work through those and see what you get for answers. Okay, that should be enough on the drug dose review. Now we're going to look at, if I can get my computer to work here, we're going to look at nervous system trauma, and I'm going to go through this one pretty quick to hit the highlights on there. So again, the things that I'm looking for on here is what is central nervous system components and what is the peripheral nervous system. On here we're looking for the different layers, so you can tell me where the dura mater is, where the arachnoid layer, the pia mater is compared to the brain. On here we talked about this and the brain using up a majority of the surface, and the skull cranium is a fixed container. Understand ICP Again, I'm not going to go through any of these things, so I'm going through very quickly. Understand ICP, basically that we're going to have the intracranial pressure. Intracranial pressure is going to do what? Well, as it expands, it's going to basically cause a herniation or a compression of the brain. So remember that. That's very important with that part of Cushing's triad, is you're going to get a herniation and pressure into that brain somewhere, because that's a fixed container and doesn't have room to grow. So any expansion or mass that goes within the area is going to displace that brain or be a herniation on the brain. That is then going to cause basically Cushing's triad, which composed of what components? Basically, it's going to be a disordered control of breathing. It's going to be an increase in blood pressure, but it's going to be a decrease in heart rate. And basically, when you see that increase in blood pressure, you're also going to see a widening of the pulse pressure, where the systolic pressure is going to go up, the diastolic pressure is going to go down, and you're going to see a widening of that as well. Key component, I need you guys to know that. Cranial nerves, again, I'm going to skip right here to this. I do want you to know all 12 cranial nerves. Specifically, what I'm going to do is I'm going to give you an example of a patient is unable or is doing this thing. One, which nerve is being tested or used. So I'm going to give some simple ones out here. A patient is not able to smell something. What cranial nerve could potentially be affected? Olfactory, cranial nerve 1. A patient is unable to see and move their eye. It's actually going to be cranial nerve number 2. The vision portion is the optic nerve, but the oculomotor and the trochlear nerves are also going to be involved with the eye motion there. Patient is smiling, lifting their eyebrows. Which nerve is involved? That's going to be our facial nerve. It's facial motions in there. Person is starting to bradycardy down. They're also, bowel movement is decreasing. It's going to be our vagus nerve. So those are kind of the things that I want you guys to be aware of, and know all of these if they come through. Again, I'm going to do a more common one. You're probably not going to see me giving you accessory nerve as one, or the glossopharyngeal nerve, but I want you to be familiar with those. So if I give you a way to test those, you can tell me what nerve it is and what cranial nerve. I'm going to scroll through these here. Again, know that there's a reflex system that's out there what the body can do with the peripheral nervous system, separate from the central nervous system. And here's that nerve root plexus as it comes back out. So once those nerves leave the spinal cord, that becomes our peripheral nerves that are out there and can be affected. That's a great picture there you can see with the anterior portion having the ventral horns and the anterior horns where of our gray matter coming out of our spinal cord. And that's going to show here again what those tracks are. And we have our meningeal layer that covers all throughout the brain down the spinal cord, ending in the cauda equina down below of the spinal roots, and so these meninges cover the cauda equina as well. Know that our nerve plexuses come out and they infiltrate the body in dermatome layers. So those dermatomes are associated specifically with the level they come out of the spinal column. So some of the key layers that I want you to know is nipple line. So which dermatome is affected if I'm dealing with the nipple line? Johnny? No, I'm asking you, Johnny. I've got a former student who's now a paramedic with me who's going to answer this question for us.
Okay, it is T4.
T4, that's correct. Good job. I gave you guys an example today of the umbilicus, which is T10. Knowing what C1 and C2 are, those are going to be some main functions that go down there. Knowing the back of the leg is going to be L4, the front, the back of the calf, L5, going down into S1 and S2 on the foot, whereas the quadriceps, starting from anterior growing, coming around to the back of the leg, are going to be L1, L2, L3. So those are all big factors to know. Another brain injuries on here. You're going to have a couple of different things with this. When a rock comes and hits the head, as this one does here, you're going to have a direct trauma to the brain. But then with that contra coup effect of bouncing around, you're going to have a diffuse injury to the brain as well. So it's two type of injuries. Anytime you get damage to the skull, you're going to have a direct injury and a diffuse injury. The direct causes the initial damage. The secondary motion is going to cause that diffuse or sloshing around. And remember, as we talk about adults and kids, our geriatric population is going to be very susceptible to injuries because they're dehydrated. The brain can move around a little bit more. The young, the brain is actually going to be very big and the skull is not as developed. So they're going to be very susceptible to injuries. It's more your middle-aged kind of area adults that going to have less problems with the brain because of the brain is fully formed, the cranial vault is fully formed, and there's plenty of fluid into the area. And this is what I talked about, those direct injuries, and you're going to have that direct injury, and then you're going to have secondary diffuse injuries. Another key concept here is the epidural versus subdural aspects. So I want you to be able to tell me the important aspect. This here would be a epidural bleed on top of that, and this is going to be mostly because it's venous blood, correct? No, because it's arterial blood. This is also going to be probably the most dangerous and quickest onset as far as bleeding. When we're dealing with our subdural, or below the dural space, this is going to be bleeding from venous blood. And what you're going to see this will diffusely come into the spaces. So this is going to be a longer onset. This will be slower to develop the herniation process because it is that venous blood as well. But it will cause a herniation, as you can see, of the brain as well. Important key concepts to know. This is after the secondary injury that I talked about was the diffuse injuries, which are going to be like our concussions, axonal injuries, and those. So that's a key concept. Again, there's a direct injury and then followed by the diffuse injuries as well. And I'm going to continue on from there. As we get into talking a little bit about ICP, as I talked to you before, again, here is Cushing's triad, which is an increase of blood pressure. And again, there is a pulse pressure widening with this. There's a slowing of a pulse, or basically the heart rate's going to go down, and you're going to get that disordered control of breathing. And here's where I talked about that pulse pressure widens. The heart rate is bradycardic, and the respirations, you're going to get a couple different reactions. So pupils, of course, can go sluggishness or completely non-reactive as well. All right. Now, when we deal with type of spinal cord injuries, there's several different things. We can get a concussion, we can get a contusion down there. These are going to be pretty much our temporary type of injuries. We can get a compression, which usually will cause long-lasting damage, but we can actually get recovery from that as well. We can get lacerations, impalements, and things like that on the cord, causing tearing and damage that can also cause effect and bleeding. I also talked to you about bulging of herniations of discs and other injuries to there. We can also get transections or partial loss. So I want you to be well versed on the concept that I went through today, as far as you get a hemi-transection of the cord. So it involves half of the body, not the entire, but you get lost sensation and motor function on one half of the body. That is going to be that Brown-Séquard syndrome for, again, hemi-aspect injuries of the spinal cord. Now, the other aspect that we're going to be looking towards is anterior cord syndrome, which is different. Bony fragments or pressure compressing on the arteries and that perfuse the anterior spinal cord. So normally our anterior cord syndrome doesn't come from an injury like a herniation or such, but it becomes from loss of blood flow to the area. We're actually compressing the arteries that feed there, and so there's no arteries perfusing that spinal cord. So the anterior cord syndrome comes again from loss of blood supply to that portion of the cord. A little bit different than the central cord syndrome, which we're going to see when we see hyperextension injuries of the cervical spine, something Dr. Edmister talked to you about with different spinal cord injuries and that as well. So that falling forward, that front facial impact is going to be more central cord, where your anterior cord, again, is going to be related to blood flow. And Brown-Séquard is going to be that penetrating injury I talked to you that only affects one side of the cord. Cauda-Equina syndrome, again, is involving that nerve plexus, or those roots that are down in the lower end where no spinal cord is at, but we get compression of those nerve roots and it interrupts the sensation. Neurogenic shock, again, to go over this, remember what we're dealing with on here is that we have a problem with the cord. Normally a transection comes down, so we are not getting a negative feedback on the parasympathetic system is what happens. So instead, anywhere above the injury of the cord, the body is going to try and compensate. It's actually going to try and squeeze down on the vessels and cause constriction. But what's happening below the injury level of the spinal cord is, without that negative feedback on the parasympathetic system, it's allowing the container to open. We actually vasodilate. The container increases in size. Our blood drains down to those areas and fills out in the periphery. So the skin actually appears pink and warm, whereas up above the injury, because everything has drained down, becomes pale and cool. So remember that key concept, and I know Dr. Edmister went over that very well with you. Way we're going to be treating these are going to be with our pressors. Is going to be a big factor. We're going to still do fluid, but pressors are going to be our big thing. Talk to you a little bit about stingers and temporary injuries, compression injuries. And this is going to be fine here. So mechanism injury is going to be a big thing. Not going to talk about standing takedowns or spinal area, but just be given a situation and mechanism injury, you guys will determine what type of spinal precautions you're going to take, whether you do full C-spine precautions or whether it's going to be needed or not. Remember, blunt injuries versus penetrating injuries. Blunt injuries definitely will need C-spine precautions. Also determine of age and the mechanism will be a big factor, whereas penetrating trauma usually does not require spinal stabilization or manual C-spine. LOC is going to be a big thing, and so apparently someone else went with a lecture with you over Glasgow Coma Scale. So I want you to be familiar with Glasgow Coma Scale. We are going to give you patient scenarios where they respond, so their verbal, whether they have verbal response to pain, how responsiveness they are. As far as obeying commands, eye response, everything from there, and I've given you the situations, we are going to ask you what is that person's GCS based on these given abilities to respond. So you guys do need to know that for Monday. We went over patient assessment and that rapid trauma assessment on there. So I do want you guys, and should be very familiar with that, and then being able to assess blood flow, sensation, and response. A test for Babinski sign, again, right on the bottom of the foot. We're looking for a positive Babinski sign is there, and as Gary talked to you about today, you're going to see the toes spreading. Great toe is going to move out and the toes are going to lift up. That's basically what we are looking for. And there's that Babinski sign test coming up, the lateral aspect of the foot heading out towards the big toe. Anytime we're doing the rapid trauma assessment and we're dealing with trauma patients, our big thing we're worried about is being hypotensive on there. One of the main things we want to do is we want to maintain blood pressure with fluid, and we want to titrate that to at least 90 millimeters of mercury with aggressive fluid resuscitation. So that's the blood pressure we want to maintain, is at least 90. We're not shooting for extremely high for the situation, but that's the goal level we want to see, and that's an important number to know. Talked about Cushing's triad, determining GCS scores, and evaluating. So make sure you know those. That will be a key component to know for the test. So I'm scanning through this. Be able to know your questions. I want you to know sample and OPQRST, and if given those mnemonics, what does each of them mean will be a key factor. I expect you guys should know that. So I'm not going to go over any more there. As far as backboarding, C-spine precautions, you guys should all know that. Know your RSI, medications, your dosages, and your order of what you're going to do will be a key component again. As far as pain medications, I'm not going to go over those. Know your medications Gary's going to give you, and that's going to be it for the nerve. So one last section, and then I'm going to be done, and this will be done with the review, is going to be my orthopedic trauma. And I want to go through just a couple of things, and then we'll be done with the review. So I'm going to skip through this and go to the points that, again, I talked to you about and think are going to be important. This is all anatomy physiology. I don't think that's so much important. I do want you to know when dealing with fractures, especially on the bones, know what type of fractures dealing with blood loss. Type 1 fractures, type 2, type 3 fractures, how much is associated blood loss, and percentages of blood loss. Those are going to be key concepts. I went over joint structures and the different type of joints out there. So given a hip joint, what kind of joint is that? And I'm going to go to the page that I'm going to find here for you. So I do want you to know that that's going to be a ball and socket joint. I do want you to know some key components there. The other thing that I want to do, and I'm going to have to come back here, is these factors here. What's the difference between a muscle cramp, a strain, and what's going to be affected with a strain, what type of injury, and what type of structure is going to be injured. When joint injuries, when sprain, again, sprain is going to affect what structures. And again, we talk about the capsule, the ligaments, and that. You're not going to be responsible for the different grades, but again, strain is ligaments, strain is, sprain is the ligaments, strain is the muscle, and we're dealing with cramps, we're dealing with muscle. Also want you to know, especially if we get traumatic injury to the muscle itself, where we get the muscle actually breaking down for things, that's called rhabdomyolysis, and make sure you're familiar with that concept. As far as dealing with joint injuries, there's two types of injuries I discussed today. Subluxation is the partial bone end displacement, so partial displacement of the joint is going to be subluxation, whereas a complete displacement of the bones is going to be our dislocations. Know the difference of them, this being a dislocation, of course, we discussed that. Now, when you come across a dislocation like this, again, what I want you to do for treatment on this is stabilize as is. We are not going to try and reduce it. We're not going to try and move it, even if there are no pulses below the level of deformity. We're going to splint in place as is and treat with medication as needed for pain. With fractures that are out there, know the different type of fractures and the mechanism that's going to determine whether you think it's fractured or not. Treat them all injuries as suspected fractures, and you won't go wrong from that aspect. Two type of fractures that I'm going to have you deal with. The closed fracture. Basically, our big thing we are going to do is we're going to splint in place and take care of it. If it is an open fracture, again, even if we just see a break in the skin, You need to make a note of that. The difference being on this now is you're going to actually cleanse the site, cover the site, and then splint in place. So with an open fracture, we're going to cover the open wound, depending on how bad it is, and then we're going to splint in place. Where the closed fracture, we're just going to splint in place. Obviously, there's an obvious open fracture I discussed with you guys earlier. Know these key concepts here. If given a picture of a bone, what's a comminuted, what's an oblique, what's a spiral, and what's a green stick. I'm not going to question you on Salter-Harris fractures, so don't worry about that. Just know that as we get older with age, we have more risks of osteoporosis and bone fractures, and that's why we are very careful for not only mechanism of injury, but as we get older, the type of fractures that could come along with that as well. I'm not going to get into bone repair. That was all anatomy physiology. I do want you to know about osteoarthritis, which is going to be basically wear and tear, versus septic arthritis, going to be infections in the capsule, rheumatoid arthritis, which is a disease process in itself, which is very debilitating in the joints, causes the hands, usually is the biggest area that we'll see it, peripheral joints. Gout is going to be that burning sensation, pain even coming close to it, most commonly in middle-aged men. At the big toe joint is the primary area, but can also happen in the ankle and the knee. And then Lyme disease coming from tick bites. Let's see. Know your secondary assessments on there. Again, this being a fracture site on this, splinting in place, not trying to reduce this fracture at all. And if that is indeed a cut there, then we would cover the wound and then splint in place. Not going to go over the 6 Ps. Another key concept on this again is suspected compartment syndrome. Biggest thing we have here is that pain out of proportion, and it's usually a burning sensation. Eventually you're going to see pallor, you're going to see a lot of different things with the skin, but those early changes are the first signs of a compartment syndrome. That your golden telltale sign is going to be as you brush against the skin, just light motions, and you're going to have that burning pain out of proportion. Also look for the mechanism of injury in those questions you're going to ask that's going to lead you further to that. We're always going to do reassessment, and we're going to keep watching up. Again, 1 is an observation, a set of vitals. 2 is a comparison. 3 is trending, and we always want to be trending to know how our patients are doing. With our sports injuries, again, I went over some of those examples today on SimMan and on Matt Carrier, so you should be familiar with assessing injuries. Talked about it, not letting it be a distractor. And immobilization techniques. Splinting, no matter how you do it, doesn't matter. Be good with the type of splinting you're there. All I want you to do is be able to say you'd splint the injury, and you're not going to reduce it. I'm not going to go over the different type of splints out there because I already went through. There's multiple out there. I'm not going to test you on splints. We are not doing any of this. As far as fracture care, you do not gently distract traction against that. We do not do any movement or resistance. Again, all we are doing is we are splinting in place. So do not attempt gentle manipulation. Do not try and move or reduce any fracture sites. So we're not doing any of this. Same with joint care. We are not trying to reduce the fracture because we can actually cause more damage to the area. If you have any area to a joint, we are stabilizing above and below the joint. That is all. And of course, then we're also going to care the area for pain management. Pelvic fractures, we're going to do the sling and swath. We're going to wrap the blanket around there. The difference is if this is truly a pelvis fracture and I'm getting compression from the top down on the pelvis, I'm going to feel that pain. I'm going to wrap it. If I have no pain when I'm pressing basically on the iliac crest from anterior to posterior, but I feel pain when I press on the side to the hip, I most likely have a hip fracture or femoral neck fracture. In that case, I am not going to put a pelvic sling and swath on that because I don't want to compress a fractured bone. Know the different type of fractures, like I said before, as far as classifications of amount of bleeding. A femoral fracture, how much bleeding are we going to get from that versus a tibia, a humerus, an ulna. Know those classifications, and I believe Dr. Edmister went over those with you. And I believe I've answered all the questions that you need to know for these areas. Like I told you, I pretty much covered all those aspects on there. Everything else is going to be basic information for you. It should be stuff you know from EMT class and skills. I'm not going to test you on any of the medications for there. We have listed, and everything else that I kind of went through should be things you guys already know. That's it. Good luck on Monday, and I will see you then.